Welcome to Evidence Mastery. I am Dr. Masood Tusi, and today we are analyzing the anatomy and evidence-based management of acne vulgaris. Acne vulgaris is a complex inflammatory disease of the pilosebaceous unit, the anatomical structure comprising a hair follicle and its accompanying sebaceous or oil-producing gland. It is a strictly biological cascade, completely unrelated to the myth of having dirty skin. This chart shows the massive demographic scale of the condition. In the United States alone, it affects over 70. Driven by hormonal signals, the sebaceous gland enlarges and floods the pore with yellow, lipid-rich oil. The second pillar is follicular plugging. Keratinocytes hyperproliferate and accumulate at the neck of the follicle, trapping the sebum inside. The third pillar is bacterial colonization. This trapped environment allows Cutibacterium acnes to rapidly multiply within the pooled sebum. The fourth pillar is the inflammatory cascade. As bacteria break down sebum into irritating fatty acids, immune cells swarm the area, causing the follicle walls to swell and turn red. If the follicle remains intact, it forms a non-inflammatory closed comedone. However, when internal pressure causes the inflamed follicle wall to rupture, it spills infectious contents into the surrounding dermal tissue, creating inflammatory papules and pustules. Every single acne lesion, from the smallest microscopic whitehead to a severe, painful cyst, originates from this exact four-step anatomical failure. The primary biological triggers for this cascade are surges in androgens during puberty, alongside hormonal fluctuations linked to the menstrual cycle and pregnancy, all of which directly stimulate excess sebum production. External variables frequently exacerbate this underlying process. Occlusive cosmetics and thick lotions physically trap cellular debris, while high environmental humidity and heavy sweating further occlude the pilosebaceous unit. This split-screen graphic contrasts biology against myths. There is no evidence linking acne to inadequate face washing, masturbation, chocolate, or sexual activity. Looking closer, we see real dietary links. High glycemic load diets, which spike blood sugar, and heavy milk consumption have documented associations with acne exacerbation. Distinguishing these clinically proven triggers from fiction empowers patients to modify behaviors that actually impact the disease, sparing them from restrictive and useless home remedies. Clinicians classify acne lesions into distinct morphological categories. Non-inflammatory lesions include whiteheads, which are closed comedones beneath the surface, and blackheads, which are open comedones containing a dark center of oxidized material. As the bacterial and immune responses intensify, lesions progress into mild inflammatory stages, presenting as superficial erythematous pustules or deeper solid papules. Severe inflammatory manifestations occur when the infection penetrates deeper tissue. Deep contiguous nodules form, often coalescing into large suppurative cysts, meaning they actively produce pus, carrying a high risk of permanent dermal scarring. The most extreme form of the disease is acne conglobata. It primarily affects the trunk of nail patients and is defined by interconnected abscesses, draining sinus tracts, and severe keloidal scars. Other severe acute variants include acne fulminans, characterized by sudden, ulcerating lesions accompanied by fever and joint pain, and pyoderma faciale, which presents as sudden erythematous plaques localized to the midface in young women. Identifying the specific depth and morphology of these lesions dictates the necessary intensity of pharmacological intervention within the standard treatment algorithm. The diagnosis of acne vulgaris is made entirely by clinical examination. It relies purely on the physical presentation of the skin, with no laboratory testing required. During examination, the clinician grades the disease severity as mild, moderate, or severe. This grading is precisely on the exact number of lesions and the presence of nodules or cysts. This comparative graphic illustrates the necessity of ruling out clinical mimics. True acne vulgaris always presents with comedones, differentiating it from conditions like rosacea, which lacks comedones entirely, or from corticosteroid-induced eruptions. Accurate severity grading and the careful exclusion of differential diagnoses provide the exact clinical parameters needed to deploy targeted, evidence-based pharmacology safely. The clinical objective of acne treatment is to systematically dismantle the underlying pathophysiology, reducing sebum, clearing comedones, lowering bacterial counts and stopping inflammation before scarring occurs. Extra washing offers no added benefit here. For mild comedonal acne, the standard protocol relies on single-agent topical retinoids, such as tretinoin. These medications act directly on the hyperproliferating keratinocytes, physically dissolving the follicular plug. When mild acne becomes inflammatory, topical antibiotics or benzoyl peroxide are added to neutralize the Cutibacterium acnes bacteria. Clinicians may also use clascoterone, a novel topical androgen receptor inhibitor that blocks the hormonal signals driving sebum production. Moderate acne requires deeper intervention. Systemic oral antibiotics like doxycycline or minocycline sweep through the underlying dermal tissue, suppressing both bacterial colonization and the deep inflammatory immune response simultaneously. Once the deep inflammation is controlled, oral antibiotics must be tapered off to prevent the development of bacterial resistance. In female patients, hormonal anti-androgens like spirolactone are often introduced at this stage to maintain long-term control. These mild and moderate protocols function as precise, localized strikes. They interrupt specific microscopic failures in the pathogenic cascade before the tissue damage becomes irreversible. For severe inflammatory acne, cystoclarians, or moderate cases that fail to respond to antibiotics, the definitive intervention is oral isotretinoin. Isotretinoin is unique, targeting all 4 pathogenic pillars simultaneously. Crucially, it rapidly shrinks the enlarged sebaceous gland, returning it to a dormant state. Achieving a specific cumulative dose over the treatment course is critical to preventing disease relapse. This systemic efficacy comes with significant adverse effects, most commonly severe mucosal dryness. Because isotretinoin is highly teratogenic, meaning it causes severe birth defects, it requires strict dual contraception protocols. Notably, previous hypotheses linking the drug to inflammatory bowel disease have now been largely debunked. For the immediate relief of isolated acute cysts, clinicians can use intralesional injections of triamcinolone, a potent corticosteroid, to rapidly reduce swelling and prevent localized tissue destruction. While acne typically remits spontaneously by the mid-20s, it leaves a substantial minority of patients with permanent physical scarring and significant emotional trauma. Addressing this aftermath requires separate, dedicated interventions, ranging from chemical peels and surgical subcision to supportive psychological counseling. Thank you for joining us for this analysis. If you found this breakdown valuable, please subscribe for more clinical deep dives. For a comprehensive guide to medical conditions and evidence-based therapies, my book, Real World Medicine, Diseases and Drugs, is available now. Acne vulgaris is a highly treatable medical condition. With timely, targeted pharmacological intervention, both the physical and emotional scars can be entirely prevented.